Hi you guys, this is Dr. BT, and I'm going to talk to you about antepartum, which means before partum or before delivery. So this is the period of pregnancy. Just a little bit about me. I have a doctorate of nursing practice. I am dual certified. I have a master's degree in women's health from the University of Florida with board certification, and I also have a family nurse practitioner certification, and I'm board certified from UNF. I was a labor and delivery nurse for years. I did high risk downtown Baptist, and then my group of nurses went out and we opened up the Beaches Baptist labor, delivery, recovery, and postpartum site. So my love is labor, delivery, postpartum, nursery. And I also do women's health in the clinic at UNF, do pap smears, pills, and take care of primary care problems, but I really do like to practice women's health. So we're just going to start off with the egg and the sperm, and obviously Michael Phelps, yep, he's first. As Ricky Bobby would say, if you're not first, you're last, especially in this given situation. So this is our little chart, and we kind of went over this before, but let's just go over it quickly again. This is the menstrual cycle chart, and it looks like just a whole lot of information, and it can be overwhelming to some. But what we need to do is we need to look at it vertically instead of horizontally. So if we look at it vertically, we can look and see what all is going on in the different body systems at the same time. So the first 5 or 7 days is the sloughing period of the endometrium, and that's when you have your menses. And so you can tell that the follicle is very small. The body temperature is very stable. There's really not a lot of estradiol. It's very stable. Progesterone is very stable. We can see that follicle stimulating hormone is starting to pulsate and cause our follicle to grow a little bit. And we can see luteinizing hormone is just pretty stable and just having a little bit of an upward rise. This is called the follicular phase because before ovulation, the follicle is maturing. So we call this the follicular phase. So we get about day 7 here. Once we have a maturing follicle, we can see that there starts to be a rise in estrogen here. This pulsatile follicle stimulating hormone is what caused this follicle to mature, and this rise in estrogen is essential for ovulation. If you don't have this rise in estrogen, you're not going to have ovulation. And you can see that this is the proliferative phase of the endometrium. You can see where it's just getting thicker. At ovulation, obviously, we're going to have a big, huge rise in follicle stimulating hormone to kick out and mature the follicle at its most, luteinizing hormone to prepare the corpus luteum to secrete progesterone. So those two are going to peak there. And at ovulation, obviously, we're going to have a rise in temperature. We're going to have some cervical mucus so the sperm can survive the acidic pH of the vagina and get to the fallopian tube for fertilization. And then we're going to have some middle smirch pain where this actual discharge of this ovum out of the ovary into the fallopian tube hurts a little bit. So we're going to have that. Now here's the secretory phase of the endometrium, and you can see that it mimics exactly the elevated progesterone. So this is why this is called the luteal phase, because the corpus luteum secretes progesterone so that our fertilized ovum can go somewhere, has a nice bed to an implant in and get oxygen nutrients. So this is the secretory phase. Without this big rise in progesterone, you will not maintain the pregnancy. And so you can see this secretive phase. You also have a secondary small rise in estrogen, but the dominant hormone of the follicular phase is estrogen. The dominant hormone of the luteal phase is progesterone. And so you can see how this corpus luteum, if there is a pregnancy, it's going to continue to secrete progesterone inside of your ovary until the placenta takes over at about 12 to 13 weeks. Now, if we do not achieve pregnancy, of course, our body temperature is going to go down. our hormones are going to go down, our progesterone will go down, our estrogen will go down. And these declining hormones are really what's responsible for PMS, premenstrual syndrome, because it's really just your declining hormones. When these hormones decline and a pregnancy is not achieved, you can see that this becomes ischemic. And when there is no decent blood supply here, you will slough off the endometrium and we'll start this process all over. So you have to know these things for your test. And the dominant hormone of the follicular phase is estrogen. Not enough, can't ovulate. Too much, can't ovulate. The dominant hormone of the luteal phase is progesterone. If we don't have enough, we cannot achieve pregnancy, or we cannot maintain it. So you guys, just a quick anatomy. The fundus, or the top of the uterus. Here's the body of the uterus. Here's the cervix. This is the portion that's going to dilate during labor and delivery. This is the external os and internal os, and you can see how long and thick it is. This is the endometrium, which is the lining of the uterus, myometrium, which is the muscle, and then the peritoneum. Here's your ovary, here's your adnexa, and your fallopian tube, and fertilization will occur here. Once you achieve pregnancy, the endometrium is going to stay intact the entire pregnancy, so that means you do not have menses when you're pregnant, and it's now called the decidua. And so decidua means temporary, and so that's going to be the temporary lining all the way through the pregnancy. When the pregnancy is over, you will shed the decidua, effectively having a menses at the time of delivery. And just a little bit about sperm and ovum. There's a ton of sperm, 2 to 5 million, live for about 72 hours. In the lab setting, they can make it live for 5 days, but that is really not conducive in the clinical setting. In the lab setting, they can live for up to 5 days. In the clinical setting, really around 72 hours, and that's because the vagina is an acidic environment, and usually they don't make it past 72 hours. The zone of reaction is once one sperm penetrates the egg, it seals, and so that two can't get in. And we can have that happen if it happens at the exact same moment, and it can cause us problems, and we'll talk about that later, but very rarely does it happen. You have one ovum per cycle. Usually you ovulate on your right side 1 month, then your left side, then your right side, then your left side. People go, well, what if you lose one of your ovaries? Well, then the other one will take over. And the ovary lives for about 24 hours after ovulation. So obviously the dad, or the sperm, is what determines the sex of the baby. So we have 44XX is female, 44XY is male. So you're going to have fertilization in the fallopian tube. That's normal. Let's look at this video real quick. Well, it's not letting me, but it's just showing you fertilization. The embryo is the most critical period. It's the first 8 weeks, and this is when we're having organogenesis. This is when all the organs are forming, and we want to avoid anything that could cause damage to those organs. And the things that cause damage, those are called teratogens. We'll talk about those in depth a little bit later on, but some big teratogens that we think about are like dry cleaning fluid. Smoking can be a teratogen. Alcohol is a teratogen. Even high levels of blood sugar can be a teratogen. Zika is a teratogen. Coronavirus is a teratogen. We already know that it can damage the fetus and the placenta. So this little development is the zygote, is the first cellular division here, and the morole is at about 16 days. And then here's the blastocyst. This is the inner cell mass, and that's going to become the embryo. And then here is a little embryo, and you can see here's the head and the tail, and you can actually see the heart beating at this point. It's very fascinating. Implantation, so you're going to have fertilization in the tube. So the sperm is going to come up in the cervical mucus all the way. That's their transport vessel, the cervical mucus. Without it, they cannot get to the fallopian tube because the the vaginal environment, the uterine environment is not suitable to allow them to survive. So the sperm will come here. You'll have fertilization in the tube. Here's when we had ovulation. So our egg was released, and then our sperm got here via cervical mucus, and then we had fertilization. So here's day 1. Here's your 2 cell. Here's your merolla. Here is your blastocyst. And then you're going to have implantation in the endometrium, usually between day 6 and day 10. And so this is great. Sometimes after fertilization. So a lot of times people will say, I came in because my period was early. And I say, what was it like? Oh, it's just a little spot. Well, that makes me concerned that it was implantation bleeding. And that's here. So again, on day 6 to day 10. Remember, this is secretory. It has a lot of blood supply, and that's why you have implantation bleeding. Here is where it is implanted, and here's the glands. We have all this secretory blood supply, which can nourish the fertilized ovum. This is just a great video to watch about fertilization. You can watch it on your own. It just shows a great video of the travel of the sperm and what it becomes. So the antepartum period, there's phases of the childbearing year. The antepartum period is before partum, or before delivery. The time of conception to the onset of labor is 40 weeks, 10 lunar months, 3 trimesters. First trimester, weeks 1 through 13. We see a lot of hormone changes in this point. Very little growth of, or very little change in mom's weight, but a lot of growth in the embryo. So we want to be very, very careful. This is our very scary time for teratogens. So we want to be very, very careful there. Second trimester is weeks 14 through 26, and this is when the baby starts to gain weight. And then the third trimester is really the baby's just putting on weight, growing, exercising his or her lungs by breathing in amniotic fluid to make, really help mature the lungs. And then, of course, they're drinking amniotic fluid and urinating it out to help mature their kidneys. By definition, there are 2 patients. What affects one affects the other. So if the baby were to pass in utero, mom could become septic. Or let's say mom's heart was to stop, obviously, that would stop nutrition and oxygen from going to the neonate. The intrapartum period, so in the middle of parting, so that's during the time of labor, birth, and the first few hours after birth. The reason why we include the first few hours is because we need hemodynamic stability after delivery, because this is the time that is most critical that you could bleed to death. Postpartum, so after the partum, it's the first 6 weeks for the new mom. So that's the postpartum or the puerperum, postnatal period, lots of different names. There's 2 patients. There's a mother and the baby. And so you guys, after 20 weeks or after the age of viability, we know that there are 2 patients to be accounted for when we're doing our triage. Before 20 weeks, there's 1 patient to be accounted for, even though the mom is pregnant. The parturient, sometimes the NCLEX will throw this word at us, refers to the woman during the childbearing year. And so they're trying to see if you understand that she is pregnant by using this word, the parturient. Partum or partal refers to the pregnant woman or the new mother. Again, the embryo is from 15 days to 8 weeks. This is the most critical period for us to make sure that baby is not exposed to very harmful substances, which are called teratogens. The fetus is from 8 weeks to birth. The neonate is the first 6 weeks, and the infant is the first year of life. So you guys, we use standard prenatal care throughout the United States. We're very fortunate that we have this type of care, because this means that you can transfer from facilities from state to state and have the same exact exams, the same evaluations, the same assessments. So it's really good. So you can have consistent prenatal care. So now let's talk about signs of pregnancy. And I apologize about this 285. I thought I had taken that off. There are signs of pregnancy, and people presume they're pregnant by things they feel. So obviously these are presumptive or subjective. You may have one objective one, which is amenorrhea. So changes felt by the woman, amenorrhea, she didn't have her period, so that would be an objective finding. But then these two subjective ones are fatigue and breast tenderness. I will tell you in very stressful times, and I see this a lot in clinic, people will miss their period just because of the stress hormones. So is this just presumptive? You think you might be pregnant because you missed your period, you're tired, and you have breast changes or tenderness. Probable, so you're probably pregnant if we see these things on exam. The first one is a positive urine pregnancy test. That's detecting urine HCG, human chorionic gonadotropin. And so usually that's a probable sign that you're pregnant if you have a positive pregnancy test. The thing is that we can have positive HCGs for different types of cancer. So it's not definitive. Chadwick's sign. So you guys, when you become pregnant, you get a lot of blood flow to your vagina and your cervix, the bottom of your uterus. And so it makes your cervix turn like this little bit of blue color because just of the lots of blood flow going there and these dilated capillaries. So that's Chadwick's sign. Hagar's sign is softening of the sides of the uterus. And then Goodell's sign is when your cervix starts to soften. That's another sign that we can see that's a probable sign. Positive signs that are only attributed to the presence of the fetus are hearing the baby's heartbeat. So we put an ultrasound down low on mom's pelvic area, and then we hear a heartbeat that's between 110 and 160, and then we palpate mom's pulse, and it's different. They have to have two different pulses, and that's how we know that there's a baby there. Visualizing the fetus, so we can look inside with ultrasound and see a baby moving in there. Or we can do Leopold's maneuvers, and we can palpate fetal movements. We can feel the baby moving under our hands. So you'll have a question on your test about presumptive, probable, and positive signs of pregnancy. This is your ACOG prenatal record. And again, this is the same thing we use everywhere. It just tells our last menstrual period, our initial exam, what we think our due dates were. And then we update it. We look in, when did the baby start moving? It should move by 22 weeks. What was the fundal height? When was the fundal height at the umbilicus? It should be there around 20 weeks. When did we hear the fetal heart rate? Or the fetal heart tones with a fetoscope, which is this cool, it's very similar to a stethoscope, but you wear it on your head that lets us listen to the heartbeat, and we hear that by 20 weeks. We can do an ultrasound that tells us when our due date is and what's our final due date. So anatomy and physiology, just real quickly. So there's the uterus, of course, that's where everybody lives inside of. That holds the developing products of conception. The placenta is the oxygen tank in the buffet. So it's the transport vessel. It transports oxygen from the uterus to the embryo or the fetus. And it brings food, it brings oxygen, and then it also, the baby's heartbeat pushes back via the two arteries, CO2 and waste. The intervillous space is the little gap where oxygen is exchanged. So you guys, I'll show you in just a second. There's a little gap between the uterus and the placenta, and oxygen and nutrients are exchanged there. Mom's blood should not exchange with baby's blood. Baby's blood should not exchange with mom's blood. They're two separate entities altogether. The umbilical cord is the transport vessels that go again to and from the placenta to the baby to take out, to deliver dinner and to take out the garbage. So we like the umbilical cord. There's two arteries and one vein. The vein transports the food and nutrients to the baby from the placenta, which picks it up at the gap. And the two arteries push the CO2 and waste away from the baby back to the placenta to take for the mom to get rid of. The trypoblast, the early pregnancy, the amniotic sac, and there's two layers. There's an amnion and a chorion. Amniotic fluid is awesome. It suspends the baby, so the baby is floating so that there are no contractures. It floats the cord so there's no compression on the cord. Babies inhale the amniotic fluid so that they can develop their lungs. So in the third trimester, we'll see them breathing on ultrasound, which they're breathing in amniotic fluid and pushing it out. They're getting oxygen through the umbilical cord. And then they also drink the amniotic fluid and they urinate it to mature the GU system. And remember, urine is sterile. Everything is sterile inside of that amniotic cavity. And then, of course, the embryo fetus is the new baby dude. So implantation bleeding, we talked about this. This is about 10 days before the first men's period. And it's when the embryo burrows into the vascular-rich endometrial bed. The finger-like projections are called chorionic villi, and they obtain oxygen and nutrients from the lining of the uterus. This is a chorionic villi right here, and you can see these condyletons. There are many of these in the placenta. So the maternal blood bathes them using hydrostatic and osmotic pressure gradients. So the maternal arterial pressure, the high pressure, pushes over oxygen and nutrients to be picked up by the fetal vein, low pressure. It's always high pressure to low pressure to oxygenate and feed the baby. Conversely, the baby's, remember we talked about this, the baby's two arteries push over CO2 and waste under high pressure to the space, and then it's picked up by the maternal veins. Again, the blood supplies are separate. And here's a condyleton right here. You can see that here's a maternal arterial. It's under high pressure. It pushes food and oxygen into this space right here, and see where it's bathing this space. And then that will be picked up by the baby. You can see right here by the baby's vein and delivered to the baby. And then conversely, when the baby gets rid of CO2 and waste, it goes through these two umbilical arteries. And you can see it goes here and it pushes through, and then it's bathed in the same place and it's picked up by the maternal vein and excreted. And here we go again. So here is the endometrial artery. It pushes oxygen and nutrients to the gap. Remember, because the bloods do not mix. Okay, the bloods do not mix. So now CO2 and nutrients are in the gap. And then we push it high pressure over, and then the placental vein picks it up and takes it to the baby. Now the baby's high pressure placental artery takes CO2 and waste and pushes it to the gap, and the maternal veins on the other side of the gap, on the uterus, take the CO2 and waste from mom to excrete it. So here's the maternal side. This is the condyletons. This is the side that's attached to mom. You can see the amnion and chorion here, the two layers, and then you can see the umbilical cord right here. And this is the top part of the placenta. And look at all these wonderfully rich vessels. Oh my gosh, you guys. This is how we get blood supply from the baby back to the decidua, and then oxygenated from the decidua back to the baby. So this is all fetal blood in here. And we can drain this out and save it and this is all stem cells. We can save it for the baby to use later on if we need. Now, this placenta is only good for about 40 weeks. It's a temporary vessel. So after those 40 weeks, this will start to degrade and start to calcify. And this is why you can't really go more than 42 weeks, because the placenta is damaged and it does not transport the oxygen and the nutrients to the baby. And of course, if it's damaged, we can't get rid of the CO2 and waste, which can cause acidosis in a baby. Other things, anything that causes vascular damage here can cause problems with our baby, like gestational diabetes or diabetes in general. It can cause damage to this placenta, and we can have, a really small baby, a really large baby if the sugar is high for a long period of time. But let's say it's really super damaged, we can have a really small baby with gestational diabetes. Smoking, cocaine, vasoconstriction, cocaine can damage this placenta. So you guys, this just shows how in early pregnancy, how the anchorin villus and the trophoblast, these spiral arteries, go into the decidua. And remember, this is the temporary lining of the uterus. So these are the spiral arteries on the decidua, okay, the myometrium's down here. And very early on, we get some oxygen and supply. And we can see our blood supply is kind of limited, but as the pregnancy goes on in the third trimester, wow, look at all the blood going through the decidua basalis to the little gap. And so you can see if we have problems with our placenta or placenta came off, we would have a major bleed compared to very early on. Oh, and this is me just showing you how you can have vascular damage and what causes it. Oops. What causes it? I can't move my picture here, but we know what causes it is smoking, cocaine, any type of big vasoconstrictives, glucose, high levels of glucose, such as diabetes, thyroid problems, again, smoking, any of that stuff. So we don't want to see a calcified placenta because these little arteries are blocked. These vessels are blocked once they're calcified and blood cannot flow to this cord and it can't get back to mom to get some nutrients. This is the teratogenic period. So this is fetal development. So here's the first 2 weeks. Here's week 4 through 8. And you can see where everything is forming here. Now the CNS will continue to form, or the brain will continue to form. And you guys, you know that even the baby's brain continues to form at 1, 2, 3, 4, 5 years old, 7 years old, 10 years old, even up to age 21. Your frontal lobe is not fully mature. So you can see that the CNS can always be damaged. But you can see here's where we have heart problems. We can have limb problems, lip problems, cleft lip and palate, ear problems, problems with the eyes, cataracts, staining of the teeth, cleft palate, and masculinization of the female genitalia. And this is why we're really conscientious about not giving you birth control while you're pregnant. So the fetal circulation, so you guys remember, they don't they don't breathe in oxygen in utero. They breathe in amniotic fluid, and that's just to strengthen their lungs. So they don't need their lungs for gas exchange. So they have some shunts. So they have, the first one is the ductus venosus, and this comes in and the oxygenated blood is shifted away from the liver, not the live, to the inferior vena cava. And remember, the inferior vena cava is what brings blood to the right atrium. The foramen ovale bypasses the lungs. It goes from the right atrium, and it bypasses the right atrium. It bypasses the right ventricle. It bypasses the whole lung system, and it just passes it straight on over to the left atrium to go left atrium, left ventricle, and out into the aorta. And then the ductus arteriosus is another bypass from the lungs and the pulmonary system to the aorta. You can see it here. So here's the placenta coming in. Here's your first bypass, which is the ductus venosus. You can see this is oxygen rich. It's oxygen rich. And now we're going to go to the right atrium is here. Here's the right ventricle. So the right atrium. So we have the first bypass duct, again, which is the foramen ovale. So the blood goes from the right atrium to the right ventricle. From the right atrium to the left atrium to go out to the left ventricle and out to the aorta. And then, of course, the last one is the ductus arteriosus. This is a very dangerous one after birth, but it connects to the vascular system, to the pulmonary system, and it just bypasses the pulmonary system and goes to the aorta. So that's it for Antepartum 1. Thank you so much.